All right, today we're tackling something pretty wild, aortic arch anomalies. We're going to break down some seriously complex anatomy and get into this bizarre clinical situation where your own arteries, well, they can basically pull off a heist. I mean, seriously, what if your own arteries could literally steal blood right from your brain? Sounds like something from a movie, right? But nope, this is a real thing, and we're going to walk you through exactly how this crazy anatomy heist goes down. So here's the game plan. We'll kick things off with the basics, the standard blueprint for the aortic arch. Then we'll look at the most common little quirk, the bovine arch. After that, we dive into the right stuff, the arches that are actually clinically important. We'll see how anatomy can literally form a ring around vital structures, and then we get to the grand finale, the subclavian steal. Okay, let's get into it. Before we can understand the heist, we gotta know the layout of the bank vault, right? So first up, what does a normal aortic arch even look like? How do we describe it? This is one of those things that sounds way more complicated than it is. It all comes down to one simple question. Where is the arch in relation to the trachea? If the aorta arches over to the right of the trachea, we call it a right arch. If it goes to the left, you guessed it, a left arch. That's it. That's the fundamental rule we build everything else on. All right, now let's talk about the variations. And look, it's really important to get this. Not every anomaly is some big, scary deal. Some are super common and, honestly, pretty quiet. And this first one, the bovine arch, is the one you're going to see most often. So what exactly is a bovine arch? It's actually pretty straightforward. Instead of having the brachiocephalic and the left common carotid arteries coming off the aorta separately, they get together and share a common trunk at the start. That's the whole deal. And it is, by far, the most common branching variation you'll find. Okay, let's pivot to the stuff that really matters. The high-yield information you absolutely need to know for exams and clinical practice. There are a bunch of different types of right-sided arches, but we're going to zero in on the two that have the biggest impact. And this is such a relief, honestly. You might hear that there are 5 different types, and your brain just starts to shut down. But forget that. For pretty much all practical purposes, you only need to get a solid grip on 2 of them. Just 2. The one with an aberrant left subclavian, and the one with mirror branching. And this slide just nails the key difference between them. On one side, you have the aberrant left subclavian. The big clue here is that the artery going to the left arm is the last one to branch off, and it comes from the back of the arch. Then you've got mirror branching, and it's named perfectly. The branches come off the front, just like a normal arch, but, well, flipped, like a mirror image. So remember that, back versus front, that's the core distinction. Okay, so these right arches have a pretty strong link to congenital heart disease, but this is where things get a little tricky with the wording. And you know what that means? It's perfect fodder for a trick question on an exam. So listen closely to the wording here because it's everything. The congenital heart disease you are most commonly going to see with the right arch is Tetralogy of Fallot. But the one it's most closely associated with is truncus arteriosus. So what's the difference? Well, while TOF is just a more common disease overall, if you have a patient with truncus arteriosus, there's a staggering 1 in 3 chance they have a right arch. That's a massive association. Super important distinction. So what happens when this weird anatomy creates a real physical problem? Because these aren't just lines on a diagram. These rogue arteries can actually form a complete ring, a vascular ring, that wraps around and squeezes the trachea and the esophagus. Let's walk through how this ring gets built step by step. First, you've got the aortic arch hanging out on the right side of the trachea. Next, that aberrant left subclavian artery comes off as the very last branch. Now, to get all the way over to the left arm, it has to swing around, passing behind the esophagus. And for the final piece of the puzzle, you have the ligamentum arteriosum over on the left, tethering the aorta to the pulmonary artery. Boom! The trap is set. The trachea and esophagus are now completely encircled. Now, a quick but important clarification. The single most common arch anomaly of all is actually a little different. It's an aberrant right subclavian artery that comes off a totally normal left arch. Now, this doesn't usually form a full ring, but that wayward artery still often sneaks behind the esophagus. And when it does that, it can cause problems with swallowing, a condition called dysphagia lusoria. And now it's time for the main event. The reason we called this an anatomy heist. Let's talk about the subclavian steal. This is where all that anatomical groundwork we've laid pays off in a really fascinating and kind of scary physiological event. Okay, first off, let's nail down this distinction because it is an absolute classic for a test question. You have the phenomenon, and you have the syndrome. The subclavian steal phenomenon just means that blood is flowing backwards in the vertebral artery. That's it. Full stop. It only becomes a syndrome when that backward flow is bad enough to cause actual neurological symptoms, dizziness, fainting, that kind of thing, because it's literally stealing blood that was meant for the brain. The key takeaway: no symptoms, no syndrome. So how does this heist actually go down? Well, first, you get a blockage or stenosis in the subclavian artery before the spot where the vertebral artery branches off. Then, the person starts using that arm. Maybe they're exercising or carrying groceries. That arm is now screaming for more blood. So what does the body do? It finds a workaround. Blood goes up the vertebral artery on the good side, crosses over in the brain, and then flows backwards down the vertebral artery on the blocked side to feed that hungry arm. And in doing so, it steals blood away from the brain's posterior circulation. The heist is complete. Now, what's causing that blockage in the first place? Well, here's a super useful clinical pearl. It really comes down to the patient's age. If you've got an adult, think atherosclerosis. I mean, it's the culprit in something like 98% of cases. But if your patient is a teenager or a young adult, your alarm bells should be ringing for something else: Takayasu arteritis. That's an inflammatory condition of the large arteries, and it should be high on your list. So think about what we've just unpacked: a tiny deviation from the body's original blueprint. A vessel that takes a slightly different turn can lead to anything from a totally silent variation to a literal ring of steel constricting the airway, and can even set the stage for a blood heist from the brain. It's a powerful reminder, right? Knowing the map of our arteries is one thing, but what does it mean when the map itself leads to a heist?